Now, in this module of, clinical examination is very important for very common pediatric orthopedic conditions, and cerebral palsy is one of them. And we very frequently see the mimickers of cerebral palsy in our clinic, and we take help of our neurology friend, Dr. Anand lyer, who has extensive knowledge, clinical acumen, and his training in pediatric neurology uh, is at phenomenal centers. So Anand is of great help in demystifying what is cerebral palsy and what is not. So in today's session, we have requested him to take us through different mimickers, which we should keep in mind in our clinical practice. So welcome, Anand. And
Thank you.
you can share your screen, and Anand is take us through the interactive session. So I would request all the fellows and trainees uh, to be interactive, to make mistakes and learn. That's the best way to learn, I think. Yeah, Anand, you can share your screen, please.
So can you see my screen?
Yes,
And full screen now.
yes.
So thank you very much, Maulin, for this invite. Um, so this is the overview of my talk. So we'll talk a little bit, very little about what is cerebral palsy, what we do commonly understand about cerebral palsy. And then I'll talk a little bit about red flags when to suspect an alternative diagnosis. I won't keep it too long. I think I've got 6 cases. They're all unique in their own way. Let's keep it interactive. We usually describe the history and show some videos, and then I'll give you a handle like an MRI or something, and then you can tell me what you feel could be the likely diagnosis. And then I'll follow it up with a brief summary of each case. And then we'll talk about some other mimics um, as well, but I don't have too much to discuss about them. I don't have a case as such. And then we'll talk a little bit about summary and take-home messages and more discussion and question answers to make it effective. So there are lots and lots of definitions of cerebral palsy. Everybody choose their own, but essentially they're a group of permanent but not unchanging disorders of movement and or posture and of motor function, which are due to non-progressive lesion or abnormality of the developing or immature brain. And not only do these children have motor function disorders, but they also have dysfunction in cognition, communication, speech, behavioral issues, epilepsy, and the list goes on and on. So in most cases, these children would, kind of cross paths between the orthopedics and pediatric neurologists. Now, there are many classifications and subclassifications of cerebral palsy. But if you look at broad categories, and I'm only mentioning this to give you a kind of a clue as to why we need to pin it down as cerebral palsy. So we can put it down as diplegia. These are the ones who clearly walk on their toes. Dystonia, so you can see a very clear movement disorder, lots and lots of writhing around. And when she's given a ball, she finds it very difficult to hold on to the ball. Or you could have a hemiplegia. So this is a child, you can see a very clear left-sided hemiplegic gait. And really, when we talk about these children, we need to have a correlating MRI. So the MRI of a diplegic, probably a history of an ex-premature child, would show these kind of wavy ventricular margins with periventricular leukomalacia. So we are happy then that yes, this is a diplegic cerebral palsy. Somebody with kernicterus or hypoxic ischemic encephalopathy might show hyperintensities in the thalami, in the basal ganglia. So we are happy that yes, there's a history that is correlating. There is an MRI that is also correlating. And you can label this as dystonic cerebral palsy. And of course, in the third child, you can see a whole right MCA, cystic encephalomalacia. This could be an antenatal or a perinatal stroke, or in some cases, you may also have a huge developmental malformation of the brain. And you're happy that, yes, you have a befitting history, you have a correlating MRI, and you can call it cerebral palsy. What are the red flags for alternative diagnosis? I think history is key. And, as pediatric neurologists, the majority of our diagnosis rests on the history. So if you don't have any risk factors, if you don't have a history of hypoxic ischemic encephalopathy or any other risk factor as such, prematurity, kernicterus, neonatal hypoglycemia, then you have to question, what am I dealing with here? If you have regression of motor and of other skills. So sometimes you have children who may walk on time, but then they forget walking or they have difficulty in walking at a later stage. Similarly, they may have regression of other skills, like they may not understand. Previously, they used to understand speech very well. Suddenly, they stopped understanding speech. They don't seem to be understanding anything taught in school. And if this regression of other skills, immediately your red flag should be, could this be any other neuroregressive disorder? If you have fluctuation of motor dysfunction or motor function, so somebody who has increased stiffness towards the end of the day, but is actually quite okay towards the early part of the morning, you'll see some cases like that. And if you have pure neurological signs, say significant cerebellar signs, ocular apraxia, oculomotor features, sensory features, then you might need to think, am I dealing with something else over here? A positive family history and consanguinity are equally important. So, I've got a couple of patients who say, um, इस बच्चे को भी cerebral palsy है मेरे previous बच्चे को भी cerebral palsy है मेरे काका के लड़के को भी cerebral palsy था. It doesn't run in family. Cerebral palsy is due to a brain injury which is non-progressive. If you have dysmorphism, it opens a big list of other disorders that might cause CP-like picture. And of course, if you have epilepsy and other significant difficulties, it can be associated with cerebral palsy, but you may need to think if epilepsy is a major phenotype, then we are dealing with some other function over here. So my simplistic approach is look at the parental history very closely, look at the developmental history very closely, and by no means I'm not asking orthopedicians to become developmental pediatricians, but simplistically, if a child is not walking independently by 18 months, then I'm worried. If the child does not say bye-bye by 18 months, and we'll talk about why this is important, because reciprocal social interaction is a very important feature to diagnose autism, an autism-like disorder. And if they're not able to speak 5 to 10 words in context by 2 years of age, and when I mean context, if they're saying mama, then they are calling the mama. They're not saying mama to any random person. So, in context, if they're not able to say these many words, then you need to think there's something wrong here. And then it's useful to fit them into a particular phenotype. So, are they spastic? Are they dystonic? Are they ataxic? And nobody comes like textbooks. So, are they mixed? And clearly, these patients, would benefit from being referred to the pediatric neurologist. And invariably, they would require focused investigations, and it would start with neuroimaging. And then in the majority of the cases, after that, once we have a certain idea about what we're dealing with, then targeted genetic investigations might help in coming to a conclusive diagnosis. So let's move on to the cases. So this is a 10-year-old boy. He was born at term, no resuscitation at birth. He walked at 2.5 years, so that's slightly late, and he has frequent falls while walking. He finds it difficult to get up from sitting position. And in examination, as you will see in the video when I play it, he walks with significant difficulty. On examination, he has spasticity in both his lower limbs. He has weakness of his hip flexors. His deep ended reflexes are brisk. He's got ankle clonus, and his planters are upgoing. So his Babinski's is positive. So I'd really like you to see the video. I can play it again and then let me know what you feel clinically. You can see how difficult he's walking. He's swaying the whole of his upper body. I'll play that again for you. He actually has normal upper limb function.
Any family history, Anand?
Actually, his sister, so they have four children. His sister also has the same disorder. But the two other siblings, who are both girls, do not have the same disorder.
Yeah.
Uh, Parents don't have it. Nobody else in the family have it.
So Sujit, yeah, first Joyance, what do you think it is? What it can be? What are the differentials we are thinking at this point? Or Joyance, are you there?
Yes, sir.
Yeah, tell
It's
me.
more like a paraplegic.
Uh-huh.
So
Paraplegic.
something. No, no. Um, some something. Either a spinal.
Okay.
Um,
So
something in the
something
spine.
arising from spine. Yeah, yeah. Preksha, do you anything else? Do you think? So, first of all, yeah, Preksha or Tashvin, do you have any clue what is going on?
So, uh, he has a sir heel of gait sir bilateral.
Yes.
So it according to sir this video and history, it may be sir I think sir diplegic. Uh,
Yeah. So one thing is the birth history has been said normal. Many times in remote places, uh, patient might have a very subtle, perinatal hypoxia, and parents are not aware. So that we see, Anand, many a times. And when we get their MRIs, they show subtle changes of cerebral palsy. So that is one thing. So normal births and no resuscitation in
No,
it's just we cannot say that it is not cerebral palsy. That's one. There is delayed milestone, frequent falls while walking. When you say difficult to get up from sitting, that means there is something proximal muscle weakness. So
yes.
I know the diagnosis, but I'm trying to bring differentials to the fellows that we should see the vitamin D deficiency induced myopathy, which we saw a lot of patients after COVID
Yeah.
lockdown. But their long-standing vitamin D can also lead to delayed walking and fall in early life and getting up. But usually, the parents would say that they were normal before, and then later on they developed this. So I think the weakness of proximal muscle is very important with a brisk reflexes and clone is a very important finding. And Sujit said HSP. That's why I asked the family history, and Anand will take us through.
Yeah.
Any other thought or comment from anyone? Then please, this is interactive thing.
So
Yes,
has
so
he
Sujit, why
ever?
do you think this is HSP or hereditary spastic paraparesis?
So, based on the family history, with this spasticity and brisk DTR and ankle clonus, I thought it could be HSP, sir, if MRI was normal.
So there are few other genetic causes of so not only family history, because we see a lot of other, and then Anand would tell us that they have genetic causes of this spasticity.
Yeah.
And reflexes are, even in cerebral palsy, we see the reflexes are brisk, and clonus we always see while we check the TA tightness. So I
Yeah,
think the proximal muscle weakness gives us clue. Yeah, Anand, please take us through. Please
I
go.
think we can still continue to, you know,
My one question before we proceed, Anand, like, can a child have cerebral palsy with normal brain MRI?
it's about 5 to 10%. But you have to be really, really careful that you have excluded everything. And it's a diagnosis of exclusion. And what we are seeing is not the typical ones that you see from the villages or from a secondary care newborn unit. If you have children, who have been resuscitated very well in an excellent tertiary care newborn unit very early, and they may have, we're seeing a changing picture of HIE, we are seeing a changing picture of prematurity. They may not have, typical features on the MRI. I would also say that I rarely take the MRI report on face value. I usually like to see the MRI myself. Many times I would request the proper DICOM images. I would get them seen by a proper radiologist and then only come to a conclusion that it is
Yeah.
normal. So going through this case, I'll tell you what exactly happened. So this was reported as periventricular leukomalacia. So what do you think about the MRI? Sorry, I'm giving you only one cut, but I think
So
you can
first,
see.
at the outset, we pediatric orthopedicians, we don't know how to read an MRI, frankly.
Oh, okay, all right,
So
okay. So I'll
my next question to you it was, many a times we see the report that MRI is normal, and then
yeah,
when patient goes to a neurologist, they say, oh, there is subtle changes of this. So what is
yeah.
the, that's again a problem we face. So
Yeah, so
we,
I think
yeah,
pediatric MRIs are very difficult, and pediatric brain and spine MRI. I mean, even I would want a neurosurgeon to look at the spine if I suspect something. But for the brain, we are very happy to see. So I'm sure you would understand that these are the ventricles inside. This
ventricles.
is the right and this is the left. The outer part would be the gray matter. The inner part would be white matter, and this is probably a flare sequence. Um, you should not see these kind of white, areas. And this is periventricular. So no doubt, somebody would report it as periventricular leukomalacia.
Hmm.
So that would fit in with what? Periventricular leukomalacia would fit in with what condition?
Yeah,
cerebral
that is
palsy.
HIE, right?
It's probably more prematurity related rather than
Okay.
HI. But
Okay.
and you get prematurity, a diplegic CP, and periventricular leukomalacia. All of that fits in with one line. Just like I showed you in the previous, the first case and the first video.
Yeah.
But if you go to the nitty-gritties, there is no prematurity here.
Hmm.
These This boy has significant weakness of the hip flexor muscles, right?
Yeah.
And so, in when you have periventricular leukomalacia, the white matter volume is also lost. So these ventricular margins will become a bit more wavy. They'll become a little bit more dilated, and you're not seeing that here. Okay.
Hmm.
So despite this being reported as periventricular leukomalacia, um, this is what we call as the ear of the lynx sign. Lynx is a form of cat, and you can see the cat's ears appear in this manner. And this is very typical sign that we see in uh, HSP, so hereditary spastic paraparesis.
Okay.
So, and if actually you look at different other cases of HSP, many of them have subtle periventricular white matter changes. They have subtle corpus callosum being thinned. They have the ear of the lynx sign. So I think if you know what you're looking, then you'll be able to correlate that as, yes, this is the condition. So going about HSP briefly, it's characterized by bilateral lower limb spasticity, maximal in the hamstrings and the gastro, and weakness maximum in the iliopsoas and tibialis anterior. There is hyperreflexia, extensor plantars, and impaired vibration sense because it does affect the posterior columns as well. You've got the pure HSP where you just have motor dysfunction versus complicated where you have ataxia, seizures, intellectual difficulties, and neuropathy as well sometimes. And the most common is autosomal dominant, and it's a de novo mutation, and it's usually caused by SPAST gene or ATL1 gene. And sometimes you can have autosomal recessive, and it's very rarely X-linked. Usually it's autosomal dominant. This child, very interestingly, did have autosomal dominant, but with incomplete penetrance. That's why two children were spared. And actually, the father was a mosaic carrier in his germ cells. That is what was concluded from the genetic report. He had a ATL1 based spastic hereditary spastic paraparesis. And treatment is usually with good physiotherapy, baclofen, orthotics. And if they have fixed contractures and other things, I think the key thing for you to be aware of is that this is a slightly slowly progressive disorder. So even if you do surgery, it would need to be backed up by significant amount of physiotherapy because sometimes it can make things worse. Um, so that's case one. Let's go to case two.
So, before we proceed to this case, now, Anand, when do you get genetic study in these cases? Now, if you find a typical MRI change, then would you go for genetic study? What is the cost of this test? And what is the advantage? These are the questions, people would like to know.
Yeah. So I think we are living in a genetic era. Everything has got a genetic diagnosis, including even, other things like autism, which is not yet confirmed to be a monogenic inheritance.
Hmm.
So, what is the advantage of genetic testing? One is we can confirm the diagnosis on a genetic level. Sometimes you may have various research groups. So, there is somebody called Darius Weberman in Colorado or somewhere who runs an HSP registry clinic and does very active research. So even though this family was from Rajasthan, we referred them to this center, and they take a lot of effort in arranging a translator and getting all the history and everything, so that in future, if there is any form of gene therapy or anything else, then they can reach out to the families. And if, of course, if they have one child, and the chances of this happening again are possible. Even though it is autosomal dominant, you may have germline mosaicisms and the family may not know. So having two children is quite devastating. I mean, this family came from a village. So what happened was four children, one boy affected, one girl affected, two girls not affected. And the father said, "Well, I can't afford, going for antenatal screening. So I'm going to go and marry another woman, and I'll
Oh.
keep both the women happy." But
Now,
yeah,
interesting.
but it's important to go for genetic diagnosis.
Can if one child is diagnosed with HSP on genetic basis, can on antenatal amniotic fluid testing we can know that whether the second child is also affected? This
Absolutely,
question is asked by a lot of families.
absolutely. So, but for that, we need the proband and we need the proband's gene testing to be positive. So, if we have it positive, uh, usually what we would do is we would do Sanger sequencing of the parents to just confirm that none of them carry the same mutation. They shouldn't have the same mutation because if it is autosomal dominant, if they have the mutation, they should manifest the disease.
Hmm.
Uh, But usually in the first 3 months, we would recommend they go for chorionic villi sampling. And
Okay.
in that, we would test for the gene mutation. If it is negative, we would reassure them that the child is not affected with HSP, with the same gene.
Right.
Um,
So
that is
first
usually
we
what,
need to test parents, that because one of them might also have a subtle disease which is not apparent, and if it is a dominant gene, then the second child is going to have that disease with a surety. But if they
well,
are, they do,
50% recurrence risk.
but there is,
So,
yeah, it's a recessive, then we should do chorionic villi sampling. Yeah.
yeah.
Okay, fine. Thank
Okay.
you.
So moving forward, this is a 11-year-old boy. Now, he was born at term. He required no resuscitation at birth, and he had normal early motor milestones. He walked by 1 year of age. That's quite interesting. And he actually presented to me with his first unprovoked seizure. So he had a generalized tonic-clonic seizure. When I took the history, he had gradual difficulty in walking since 4 years of age. He finds it difficult to run. Again, he finds it difficult to get up from sitting position. And on examination, he has spasticity in all the four limbs. The lower limbs are more affected than the upper limb. His reflexes are brisk, plantars are upgoing. And he's got very slow responses to questions. So I asked him some simple questions. Which school do you go to? What's your school's name? Which year standard are you studying? What's your teacher's name? And he doesn't, he just looks at me with a blank expression. So I'll play the video. And again, um,
So there is regression in walking pattern. That's what you say?
yes, absolutely. So he walked well at 1 year and then he's got regression. But the point to understand, the two other handles here. So in neurology, we look at different handles, where you catch something and go forward. So the seizure is one handle.
Yes.
And the second handle is the slow responses to questioning. So
Hmm.
not only has he had motor regression, but he's also had cognitive regression. And, if you think simplistically, there's involvement of both the gray and the white matter here.
So there is academic regression also, as you say here. Yeah.
Absolutely. Absolutely. So any thoughts about what this could be?
Anyone smarter than me? Like I don't have any clue. Sujit, Joyan's,
Shall I show the MRI? That might
that
make a bit.
it will not make any difference, but you can show us.
Okay. So T2
Yeah.
images. Again, you can see the ventricles. This is the right side. This is the left side.
Yeah. So
Any thoughts?
no,
So
anyone?
anybody can. I don't know if anything is coming up in the chat function. No. Um, So this is a worrying history, isn't it? It's a
Yeah.
worrying history, that not only motor regression, but cognitive regression and seizures as well. Now, this is the gray matter, and the white matter should be dark gray. Can you see this dark gray where I'm pointing,
Yeah.
right? It's not dark gray elsewhere, isn't it? It's all white. It's all
Is it
white.
some form of CV stroke are we dealing with? I don't know.
No, because if you have a stroke, you will usually have a unilateral stroke, isn't it? This is
Okay.
a symmetrical bilateral picture.
Right.
And actually, it does look as if there's a little bit of a tiger-like stripes, but essentially the white matter is entirely,
Replaced.
abnormal.
Hmm.
Yeah. So this is a leukodystrophy.
Oh, okay.
This is leukodystrophy, and this is actually metachromatic leukodystrophy. So leukodystrophies as such are a big cohort of disorders that can mimic CP. And metachromatic leukodystrophy is a neurometabolic or a lysosomal storage disorder. So essentially, because of a genetic mutation, there is a deficiency of a particular enzyme. And that enzyme is important to clear out some kachara in the brain, which is called glycolipids. Because of the lack of the enzyme, these glycolipids accumulate around the white matter and they start causing the brain to get damaged. And there's also some involvement of the gray matter inside, and that's the reason why they have seizures and loss of cognition. You have two phenotypes. You can have an infantile onset as well, late infantile onset, where children may not learn to walk and they start having symptoms right early on. But this boy had a juvenile onset where he learned to walk on time. And this is there since birth. The mutation is there since birth. They have all the difficulties since birth, but at a certain age, it becomes so intense that they start having symptoms. And the key thing is motor regression, cognitive regression, and seizures. And this is an interesting condition because if you pick it up very early, then hematopoietic stem cell transplant may actually arrest the disorder and prevent progression. Because if you don't do anything, then these children become vegetative and eventually they die because of aspiration. So it's an important condition to detect, important to do genetics because that will give us a confirmatory answer. Treatment is usually supportive with anti-seizure medications, baclofen, diazepam, and adequate counseling as to, this is the cause of the condition therapy. Okay, so moving on, this is a very interesting case. It's a 4-year-old male, born at term, no resuscitation at birth, slightly delayed walking, noted to fall frequently, again walks with some scissoring and occasionally on tiptoes, seems to walk better in the morning, becomes more clumsy towards the evening. On examination, there is no significant weakness or spasticity, but if you go and touch his limbs, only then he becomes a little bit stiff. His reflexes are brisk, his plantars are downgoing, and there's a subtle lack of dexterity when using his fingers. So I'll play the video. Shall I play it again for you?
Yes, please.
You can see he walks with a scissoring gait.
Yeah, no, a lot of
Typical
imbalance also,
balance also, yeah.
and the child is constantly gazing down as if he's having issues with depth
Vision.
perception,
Yeah.
and the neck is a bit tilted. Are we dealing with some extra pyramidal thing here?
Yeah, there's a bit of dyskinesia, a bit of dystonia as well, isn't it? You could say that, he's walking on his tiptoes. He's
Yeah.
not always spastic.
Yeah.
So what would you do? What would, if this child presents to you, again, there's no perinatal history, isn't it? He was born at term, no resuscitation, slightly delayed walking. You have to confirm that it is CP.
So we'll get
So,
an MRI brain first.
so MRI brain and spine are normal.
Um,
And they are normal. It's been reviewed by a proper neuroradiologist, pediatric neuroradiologist, and they are normal.
So
Is
earlier,
there
if MRI is normal, then we tend to refer it to pediatric neurologist, and they would do metabolic workup. And
yeah,
in current era, many of these children receive genetic workup as well, genetic testing. So
yeah, yeah.
yeah.
So is there any handle here that might give you a clue about what could be the diagnosis or what could you do in terms of treatment?
So you mentioned a subtle lack of dexterity in when using fingers.
Yeah,
So is that points out to something? And
yeah,
morning is better in morning and
yeah.
more
So
clumsy. Yeah.
do you know of a condition, a CP, which occurs only in the evening? Have you heard this analogy? CP only in the evening,
No,
not in the morning.
I'm not aware of this. Sorry. Anyone? Any clue?
Anybody? So I've treated this one as well. This another child actually who came with his mother in a wheelchair, and she had a similar history. This was when I was in the UK, and she
Okay.
had a similar history that in the morning I do all my kitchen chores because by the afternoon I have to use the wheelchair. I can't move without the wheelchair. So I'm sorry I don't have a video to show you for this child.
Myasthenia. Sujit is saying is query myasthenia. I'm not sure.
Myasthenia will not usually have this kind of spastic gait, but you're right in thinking of myasthenia for diurnal changes. But they usually have ptosis and weakness and other things rather than this kind of dyskinesia, dystonic walk, scissoring walk. Um, yeah. So I gave the treatment to this child, and I also gave the treatment to the mother, and both of them got cured. They started walking normally and there was no diurnal changes. The CP was essentially cured. Can you think of any specific treatment that can cure this condition? Somebody's written myotonia. Yeah, myotonia is a good thought, but myotonia will not have diurnal fluctuation. Particularly myotonia congenita will not have diurnal fluctuation. It will remain the same. It probably gets worse in cold weathers. Lambert-Eaton is again a type of myasthenia. Myasthenia will have ptosis and weakness and articulation, dysarthria, those kind of features, not CP-like features. So this is a very nice condition to think. So is there any treatment that can cure the CP?
See, I think this Syndopa thing people are using for various things. Is it? I'm just.
Yeah, yeah. And what do you think? What condition is it that will help? Okay, so I
Yeah,
did
yeah,
give
yeah.
um, levodopa, and actually this child became completely well. And even the previous case, the mother also then afterwards came to clinic walking, having abandoned her wheelchair because she no longer required the wheelchair. This is dopa responsive dystonia,
Dystonia. Yeah.
and it's called Sagawa disease. And I don't expect you to understand this pathway very well, but essentially for dopamine to be converted to from tyrosine, you need a cofactor called tetrahydrobiopterin. And in order for tetrahydrobiopterin to be formed, you need to have GTP, and that is the pathway with which this gets activated. So if you don't have this enzyme called GTP uh, hydrolase, then the neopterin pathway will not lead to formation of tetrahydrobiopterin. Because of tetrahydrobiopterin not being there, tyrosine will not convert into dopamine, and that's why you get this condition. It's a genetic disorder. You just give tiny doses of levodopa lifelong with good physiotherapy, and the CP is cured. So this is quite a gratifying condition to treat.
So why they do worse in the evening?
Because they have some residual enzyme. So what happens is at night, your dopamine stores get repleted because it starts working. So in the
Okay.
morning, they are reasonably well, but as the day goes on, the dopamine gets depleted, and that's why they become worse towards the evening
Okay.
and fall more often afterwards.
Okay. Okay.
Okay, so moving on to the fourth case, this is a 9-year-old girl. She was born at term, no resuscitation at birth, walked on time. She had gradual onset of difficulties since 7 years of age, had difficulty walking, eventually became bedridden, significant twisting of the hands, not able to talk, not able to eat, and because of that had significant weight loss. And she had significant dystonia affecting all the four limbs with a lot of twisted postures of the limbs. But actually, in between, there was no residual spasticity when she was relaxed. Her reflexes were normal, plantars were downgoing, and no doubt because of all of this, she had significant agitated behavior and cried in a very loud pitch. So I'll play this video. So you can see how, twisted she remains in that posture all the time. She can extend her legs, but becomes very, very stiff. Um, I'll just go to the MRI. So this is the MRI, and this is the basal ganglia.
Yeah.
Okay, so that seems to be quite affected, isn't it? The caudate, the putamen, all of these are affected. So can you think of any condition where the child was fine at birth, started having gradual problems after a certain age, significant dystonia to not be able to walk, talk, eat, and cause significant weight loss, and with basal ganglia involvement?
So it's kernicterus is one which we see
Yeah,
uh, is a history, but
kernicterus problems since birth. They will not
okay.
be normal at 7 years of age. So this was something that occurred later on,
Hmm.
but she did not have any illness or anything to cause this. I'm
Could
just
this be
aware.
storage disorders?
Sorry?
Storage disorder?
Storage disorders, usually they don't store in the basal ganglia only. The storage disorders are usually in the white matter and other areas more commonly. Um, but yeah, it's one of the thought process. But is there something which is very, very common or, seen more by adults rather than pediatrics?
Mm.
So this child got actually labeled as a mitochondrial disorder and was the family were told kuch nahi kiya ja sakta. They gave them a lot of coenzyme Q10 and all of these things and said that's all seva karo. But I just wondered, why didn't anybody think of this particular condition? So shall I go through the what is this? Yeah.
Yeah, tell us
What
what is it?
what if I showed you the video of her afterwards? So this is after treatment within 6 months.
Oh, wow.
You can still see some dystonia of the left hand, but she started walking, she started talking, normal weight, then going to school and becoming her normal self.
So this is
So some,
something correctable thing.
yeah. Any thoughts now? So this is Wilson's disease.
Wilson's. Oh,
Yeah. And usually you may have even the Fleischer ring. This is a disorder of copper metabolism and copper accumulates. It's a genetic condition present since birth, but it starts manifesting at a certain age. Usually the copper and keratoplatin is low in the serum, and you do 24-hour urinary copper studies to prove this is Wilson's. But as soon as I saw this MRI, I was like, yes, this is Wilson's. Let's go ahead with penicillamine to chelate copper. Let's give some zinc to prevent intestinal absorption of copper. And with dystonia medications, within 6 months, she was back to her normal self, nearly back to her normal self. So it's a lifelong disorder, lifelong chelation required, but can present as CP.
hmm.
And time and again, we've seen that this presents with CP. They can present with strokes on the background of CP, but you need to be careful. So let's go to the last.
What is the incidence of this? Like,
It's
is it
rare.
very, very, very rare?
It is rare. It's about 1 in 10,000. So it is rare. But we do see this commonly. So as neurologists, if we see somebody with late onset dystonia, acquired dystonia with this basal ganglia changes, or a new onset of movement disorder, we would always think about copper and cheiloplasmin because it's a treatable disorder. We want to always catch a treatable disorder. So this is case five, second last case, 7-year-old boy born at term, no problems at birth, walked late at 3 years of age. He has difficulty in walking, which is progressively getting worse. He has no seizures, his cognition is preserved. And on examination, you can see how he has significant dystonia with upper limb and lower limb involved. There isn't a residual spasticity, reflexes are normal. But look at how his face lacks expression. So it takes very, very slow steps. So significant dystonia affecting his upper limbs. The face is very expressionless. Um, so again, I just present the MRI so that you can think about. Have you seen this condition at all?
Yeah, I mean, I have heard about this tiger's eye kind of appearance and
Yeah,
various neurology lectures about what is not CP, but I don't remember. We have Dr. Risha Madhuri, ma'am. She was head of Department of CMC Vellore, and she
yeah.
is one of our mentors and teachers. Parkinsonism symptoms. That's what ma'am is asking. Is it
Yes,
right?
Parkinsonian symptoms, absolutely. And this is actually very relevant to this belt in India because it's common in certain Agrawal and Gujarati communities in this part of the country.
Okay.
So this is actually iron deposition. This is a disorder of iron metabolism. It's called a neuroferritinopathy, and it's called neurodegeneration with brain iron accumulation. And usually children have subtle delayed walking, but then they start having progressive dystonia, dysarthria, rigidity, and a lot of Parkinsonian features. And sadly, the cognition can be fairly preserved. The most common gene is the plantathenet kinase associated neurodegeneration, but you have younger onsets with disorders with called PLAN and mitochondrial protein associated neurodegeneration called MPAN. But the phenotype is vast, even for a pediatric neurologist. Unless you're working in a center exclusively for this, it's very difficult to keep up with the trends. But most of them are picked up by genetic diagnosis and treatment is usually symptomatic. The thing to mention is that some of these dystonias can be so bad in this condition that they can present with torsional fractures. And that's how they come to the orthopedicians because they've had a significant fracture. And if you fix them, they will again go on to fracture because the dystonia needs to be controlled optimally. And sometimes medicines don't work, and you need to go for things like deep brain stimulation to treat this condition. Chelation usually doesn't work in this disorder, sadly. Last case, 7-year-old boy, history of consanguinity, normal birth and early development, gradual difficulty in maintaining balance, stumbles and falls often. He's prone to repeated chest infections. That's the handle. On examination, he has ataxia mainly with a broad-based gait. He does not have any spasticity, but has some dyskinetic limb movements. And otherwise, the reflexes and other things are normal. So you can see a very, broad-based, very imbalanced looking gait. And again, a lot of them may be mislabeled as CP. So I'll show the MRI. So this is the MRI, and this is the cerebellum, okay?
Hmm.
And you can see the cerebellum is markedly atrophied. All this white lines indicates there is atrophy of the cerebellum. So can you think of any disorder which presents with significant ataxia, prone to chest infections, cerebellar atrophy, progressively cerebellar atrophy? And if I give you another clue, then this is his eye, and it's got a lot of dilated blood vessels in his eye. So this is a condition called ataxia telangiectasia.
Hmm.
And again, a genetic condition which has dysarthria, oculomotor apraxia, then can go on to have cognitive difficulties. Um, they're at risk of malignancies. There is some evidence that betamethasone can help in these conditions. So, moving on, I think this is a very good paper mimicking, describing all the mimics. Now, I can't mention everything, but spinal dystrophism is always important to rule out, particularly when you have a paraparesis. So, a spine screen MRI is absolutely important. And then we have seen some teenagers presenting with late onset paraparesis in whom sometimes they have deficiency of biotinidase, which is an enzyme responsible for biotin metabolism. And in these cases, giving biotin is very helpful in reversing the disorder. In terms of dyskinetic, we have seen dopa-responsive dystonia, Wilson's. Another disorder to mention is glutaric aciduria, which presents with big subdural hemorrhages and a dyskinetic CP-like disorder. Again, this is very evident in MRI. And in ataxia, apart from ataxia telangiectasia, Friedreich's ataxia can also present with sometimes mixed upper motor neuron and lower motor neuron signs. So that's important to keep in mind as well. But this is a good paper by Lucinda Carr that you can read. Now, I just wanted to mention toe walking before I finish. So, we see most of these disorders currently And there can be idiopathic or habitual toe walking, but you need to think about autism sensory features and compare that with this boy who has toe walking, where you can see a significant waddle to his hip and very bulky hypertrophy of his calves, which is usually seen in Duchenne, and they have the typical, Gowers positivity. They turn onto their front and they gradually climb up their legs. So autism and Duchenne muscular dystrophy, and sometimes they can be co-associated. I've had two children who were referred to me because of autism, but actually they had Duchenne muscular dystrophy. They hadn't got a single clue that they had Duchenne. So that is much more a worrying diagnosis than simple autism. So moving on to summarize, I think careful history taking is paramount. That's what we pediatric neurologists are here for. Developmental screening is important. It's important to classify the phenotype, look for associated weakness in other neurological features. And I think MRI brain and spine is the most helpful investigation. But if it is normal, I would not just dismiss it off that this is a scan negative CP. I would still look for an alternative diagnosis. And the second important test is genetic testing, particularly whole exome sequencing. But we are in the era of precision medicine, so we can only treat if we know what the condition is. You've seen some disorders like dopa-responsive dystonia and Wilson's, where once we know the condition, they have remarkably good outcomes. So always think about, could this not be CP? If it's not fitting the classical phenotype, if there's no significant MRI changes, then we are here to collaboratively work and come to a conclusive diagnosis. Thank you.
Yeah, thank you, Anand. You can stop sharing your screen so that we can see you. So that was a wonderful talk. We all are well equipped to diagnose the subtypes of proven cerebral palsy and to treat them. But many a times we come across some puzzling cases which don't fit into a typical cerebral palsy. And I'm sure that this 7 cases will keep us thinking. I have written all the pointers you have mentioned in each case. That was fantastic. I've attended many lectures of what is not cerebral palsy. And in the middle of the lecture, we lose interest, but you kept us engaged. And that was very lucid presentation. Risha ma'am is here. Ma'am, any comment on this? Or I loved this talk. And
I really enjoyed the talk. I'm feeling inclined to join you more often after listening to this. So
yeah,
I think it was good. It was very informative. Just a few things when you talked about the I know you touched it only briefly, and the neurological symptoms are the major feature in the biotin deficiency. It would be nice if you just tell us a few of the orthopedic symptoms on that, because I know that the neurology and skin are much more, and plus the organs are more important. But could you just, in the biotin, just touch a little bit on what you see in orthopedics so that we know when it comes to us?
So in many cases, madam, they usually have significant dystonia and a gait disorder. So they walk with, 4-foot varus. They can have significant stiffening of the lower limbs when they're walking. Those are the most common neurological and orthopedic overlap features that I see. I don't see any fractures or any significant problems
So
with
why
that.
I ask you is biotin deficiency neurological presentations are usually biallelic. So we saw a whole lot of patients, I think about 8 when I was working on OI, and we saw about 8 patients who had either had a fracture or deformities. And when we were doing a genetic analysis, they were monoallelic biotin deficiency with a borderline deficiency of the actual enzyme on the blood test, biotinidase. Minor deficiencies were there. They were not very major, and they were not, I think it was like, I think 1/3 or something is supposed to be very severe, and it was just around 1/3 or slightly more than 1/3 it was. So they didn't have neurological symptoms. One had skin features or biotin
Yeah.
deficiency, but they all had osteopenia, and some had deformities and some had fractures, right? That's why I thought maybe you would be seeing a more spectrum in the family members or something like that. Where did you see anything in the family members? Because they'll be monoallelic.
think biotinidase presents in two age groups. It's a bimodal presentation. So the infants usually present with seizures, developmental delay, the
Yeah.
skin
Yeah.
expansion, all of these things. So that's very, very typical. They present with pure epilepsy and developmental delay, so they come to us. But you have a later onset partial deficiency which presents in teenagers, and we don't know why they present late and why they've been so well for so long. And I believe many of your cases who have these partial deficiencies, they may have some form of paraparesis or they may have some form of dystonia, and they may have had immobility for a while, and that could have led to its osteopenia and then fractures rather than biotin directly causing a problem in such a way. But for as a pediatric neurologist, if I see a late onset paraparesis and I don't have a clue, I don't have any clues from the radio neuroimaging, um, or if I have subtle features of myelopathy but without a definite transverse myelitis, I would usually treat these children with biotin and with very good results. Many of our children may not be affording enough to do genetic tests or even do the test for biotin-based deficiencies. These are expensive investigations. So sometimes, I've given a trial of biotin, and within 2 weeks, they have a remarkable improvement. And there is another condition called biotin thiamine responsive basal ganglia disease. Again, these are all pure neurological disorders, and the list can go on and on. But these children also have similar subacute onset of dystonia, and they respond to a combination of biotin and high dose thiamine. So, in the list of treatable movement disorders or gait disorders, one always needs to consider biotin thiamine responsive disorders, or this is particularly biotin induced myelopathy, which can present with paraparesis and may not have any significant changes on MRI as such.
Other thing of interest is the differential diagnosis for toe walkers, because I think that is something which all of us face all the time, and many times we don't have a clue. And one of the conditions that which I saw twice at least is in the nail patla syndrome. I was wondering whether you can give us a wider differential for the sake of the fellows as well as for us orthopedic surgeons, whether you have a little wider differential diagnosis for toe walkers other than the standard things that we have, because they
Right.
shorter TA is one of them, but neurology will have so many more differential diagnoses.
Madam, from me, for a simplistic approach, I think the first thing I would think about is, have we excluded the spinal dysraphism? I think that's very, very clear. And second thing I would look at is, do they have any proximal pelvic weakness? Do they have a calf pseudohypertrophy? Do they have a positive Gowers? Because Duchenne is it's a groundbreaking diagnosis for the family, and they need to know. So those two are, the main things that come to my mind. Then afterwards, you can have idiopathic toe walking or habitual toe walkers, autism. These are the main things that I look at when I see toe walking. I mean, the list may be quite huge, but I see these four as the more common causes of toe walking in clinical practice. If you have to have a simple frame of, thought process, then I usually would make them walk. I would make them get up from sitting position. I would check for their hip flexor strength and weakness. I would look for sacral dimples and reflexes and planters and those other things. The DOPA responsive dystonias can also present with toe walking. Some of the early neurodegenerative degeneration with brain and accumulation can also present with toe walking. So in summary, I think we once we suspect these things, we have to move forward with focused investigations, and neuroimaging would be often something that would give us more clues to go ahead with conclusive diagnosis.
So toe walking, I think it needs a session and with the multiple experts on this, because there are orthopedic problems, there are neuromuscular problems. And it as ma'am says, it puzzles us many a times. Everything else is okay. More we see patients from abroad, like Australia and UK, they have more sensory issues, and they need casting also more frequently. They're more tight, significant contractures. So thank you, Anand. That was a wonderful talk. And this opens my mind that we have sessions in POSICON about innovations in pediatric orthopedics, where MedGenome is going to help us with that session. And we are going to have genetics in pediatric ortho. We should have genetics in neuromuscular pediatric conditions. So I'll keep that in mind. And madam, next time we have a similar, we are so fortunate to have good clinicians with us. Next week, we have similar talk on what is not rheumatoid arthritis. So we are going to talk about mimics of JIA, and Dr. Pooja Srivastav is there. So I think that will be also an interesting talk, just like today's. So thank you very much.
Thank you. Thank you very much.
Yeah, thank you,
Thank
ma'am.
you.
Thank you, everyone. Have a good day. Bye-bye. Thanks, Anand. Bye.